Thank you. All right, so I did prepare a few questions. I was hoping there would be more people so I could ask questions. So we'll see how it goes. And people who are doing virtually, please chime in if you know the answer. I'd like to give you guys a chance to see what you think is the answer, and then we'll go over it briefly. And at the end, I'll just go over some of the things that I remember from PEDS boards. And, I'm actually doing my MOCA PEDS right now. So I'll tell you what kind of questions that I'm seeing and what I wish I had looked up right before the exam, and some of the things I know for sure I've seen on prep questions and board exam. And these are hopefully what you guys also encounter. All right. So first question is, you're asked to consult on a 4-week-old X39-week infant who presented with a tonic-clonic seizure to the emergency room. Labs show a calcium of 5, phosphorus of 9.5, which is elevated. PTH is 2, which is low. Alkaline phosphatase, BUN, creatinine, albumin, and 25-hydroxyvitamin D are all normal. What is the most likely diagnosis? What do you guys think? So this patient has a low calcium, high phosphorus, low PTH, and it's a baby. Okay. DeGeorge? Yeah, it is DeGeorge actually. So it's a 4-week-old. It's very unlikely this 4-week-old infant has hypothyroidism from, autoimmune hypoparathyroidism, right? Whenever you have a low calcium, high phos, always think PTH problem. And this question I added in the PTH because, what if this PTH was like, say this baby or this kid was like 4 years old and the PTH was like 2000. That would be consistent with pseudo hypoparathyroidism, where they have, and the calcium is 5, they have resistance to the PTH hormone. So that's why this is not pseudo hypopara, because that PTH is low. When you have this kind of low calcium, you are supposed to have a very robust PTH trying to get the calcium levels to go high. So DeGeorge syndrome is 22q11.2 deletion syndrome. They love this question on board exam, and I'm fairly certain I've seen it. Classic triad of congenital heart disease. They may give you an X-ray, kind of suggesting thymic hypoplasia, and we get involved because of the hypoparathyroidism. They may also have recurrent infections. Usually the classic is low PTH, low calcium, and high phosphorus. And like I said, PTH helps to absorb calcium and phosphorus from the gut and from the bone, and increases reabsorption of calcium and excretion of phosphorus from kidneys. So you treat these kids with calcium supplementation, but also activated PTH, which is calcitriol. So they need both. Yeah, so low PTH, low calcium, high phos, think hypoparathyroidism. You have a high PTH, low calcium, high phos, think PTH resistance, pseudohypopara, okay? All right, so we're not going by topic, I'm just kind of mixed up all the questions. So a 17-year-old female presents with palpitations and chest pain. Her family history is notable for multiple family members with autoimmune thyroid disease. On physical exam, she has a heart rate of 120, blood pressure 142/87, a symmetric non-tender goiter that is visible with neck extension. There's no bruit or palpable thyroid nodules. She has a mild hand tremor with arm extension, and she's got mild proptosis. Labs show a TSH is less than 0.01. Free T4 is 3.9, which is elevated. Her TPO antibodies elevated, her TSI is elevated, thyroid stimulating immunoglobulin. The next best step, what is it? All right, what do you guys think? People in virtual? C. Okay, so all right, let's go over it. So this patient has what? Hyperthyroidism, right? She's got positive antibodies, she's got a positive TSI. She is very symptomatic. She's tachycardic, her blood pressure is high. This is classic. We see this about once every 1 to 2 weeks in clinic, right? So American Academy of Pediatrics and your board question will recommend medication treatment initially, okay? There have been case reports of you precipitating a thyroid storm if you went directly to a radioablation or an immediate thyroidectomy. Nobody's going to touch her like with a free T4. That's, I mean, this is kind of, it's okay, 3.9, but usually you see like greater than 4.5 or something. They're not going to. So you are going to start her on a beta blocker to get her symptoms of tachycardia, her blood pressure better controlled, and you're going to start her on methimazole, which is going to decrease her free T4 levels. And the propranolol is, it's not the, it's great because it decreases the peripheral conversion of T4, free T4 to free T3, but it is cumbersome. It is 3 times a day, but this is the answer for board exams, beta blocker and methimazole. And say if this patient did get started on methimazole and in real life, you know, they are having some side effects, then you think about glucocorticoids. They also help with that peripheral, decreasing the peripheral conversion. And, you know, that may be the bridge to get them to radioablation, but the classic answer is you want to start with propranolol and methimazole. So she's got classic symptoms of Graves. The symptoms can include changes in behavior, irritability, fatigue, nervousness, palpitations, tremors, diarrhea, diaphoresis, weight loss. On exam, they can have a goiter, exophthalmosis, mild lid lag. They can also have increased height velocity, advanced bone age, and oral medication treatment is usually recommended as initial treatment prior to definitive therapy. In adults, there's a higher chance of remission with oral therapy, but with kids, it's less than 30%. With the methimazole treated kids if they're treated for 2 years, there's 30% chance or a little bit lower for remission.
No, lots of people.
Not usually. I've had a few kids, but usually it's Graves, and then, you know, usually 2 years. Not usually, not usually. Yeah, so I've seen this before. They give a normal TSH in a patient, but an elevated total T4. They purposefully will not give you free T4. And the patient is like a 16-year-old female. She's on oral contraceptive pills. So they have an increase in thyroid binding globulin, which increases their total T4. So always look for the free T4, okay? All right, so a 14-year-old female presents with 1 week history, or sorry, presented 1 week ago. Sorry, she had like a viral URI, and then she presented with like neck pain, mild jitteriness, fatigue, and arthralgias. Our physical exam shows heart rate of 90, blood pressure is 129/86, a temperature of 100.2. Her thyroid gland is enlarged and tender without nodules. Lab evaluation shows a SED rate of 50, slightly elevated white count, and the TSH is suppressed, and a free T4 is elevated to 2. Radioactive iodine uptake is low. What is the most likely diagnosis? So
Subacute.
subacute, yeah. So this is another question that I frequently see in prep questions and board exams. So this is subacute thyroiditis. This patient's got a very tender gland. They have an elevated sed rate, slightly elevated white count, and they have an elevated free T4. So you're like, okay, this is probably could be Graves' disease, but you get a radioactive iodine uptake, which is low. So all the release of the hormone is preformed hormone. So it's not actually active. So that's why your radioactive uptake is low. And this is temporary. This is the kid, Dalton, that you would not treat with methimazole because you're worried that they're going to become hypothyroid. Yes. So classic presentation. They may have like a viral URI or something. First, they have this phase where they're thyrotoxic, and then they may become hypothyroid and eventually will get to euthyroidism. They usually have a painful thyroid gland. They may be tired, low-grade fever, arthralgias. The radioactive iodine uptake is low compared to Graves' disease where it's high. And treatment is symptomatic with just NSAIDs and then maybe glucocorticoids if the pain is really severe. And some of these kids may need eventual levothyroxine treatment, but usually resolves by itself. All right, questions? Anything else so far? All right. All right, so this is the patient that I saw a few weeks ago, but I thought it would kind of help us talk about a couple of things. So a 14-year-old male presented for consultation of short stature. Patient's weight has increased from 45th percentile to 75th percentile over the last 4 years. During the same time frame, his height percentiles declined from 50th percentile to now below the 3rd percentile. His pediatrician said he's only grown like 2 inches in the last 2 years. He has normal blood pressure and heart rate of 60. He has puffy and coarse facial features, a flat affect, and decreased reflexes. His bone age is delayed to 9 years of age. The most likely diagnosis is what? All right, let's see who's here. How about the newborn team? Anybody else? Who is the peeps?
Hey, it's Jeremiah.
Hey, Jeremiah, what do you think?
No,
I'm
it's
leaning
a lot.
toward, we collectively thought Cushing's. Although
Cushing's?
Hannah Rugg thinks primary hypothyroid.
Who thought primary hypothyroidism?
Hannah Rugg.
Yes, Hannah. Awesome. All right, so this patient has primary hypothyroidism. Actually, he had one of the highest TSHs I've ever seen, 864. So this patient's actually pretty classic presentation. So he was gaining weight, looked flat affect and just decreased reflexes, and his height was just declining, and bone age was delayed to 9 years. This is classic for untreated and very severe primary hypothyroidism. His free T4 was undetectable. So I'm assuming he's going to have autoimmune thyroid disease, but doesn't matter, 874 TSH, and this is how they present. So 14-year-old male, you also worry, okay, he has now delayed puberty because he was Tanner 1 on exam, and if I didn't know about all of this, you know, he would have received a workup for delayed puberty. For girls, it's 12, for boys, it's 14. So yeah, he had primary hypothyroidism, and the treatment is levothyroxine. It is not growth hormone deficiency because they usually have declining height percentiles, but weight percentiles are preserved. but do not usually increase. So Cushing syndrome is a really good thought and possibly could be, but a board exam, probably not in real life. And in real life, you would have maybe thought about it if you didn't get that TSH of 870 something, but you definitely would have gotten more in terms of, he's had some growth failure, purple striae, there's a round facies, central obesity. It probably will give you some elevated blood pressure, hyperglycemia, so things like that to kind of steer you towards Cushing. So I don't think so, but in real life, different story. Board, I think it'll be pretty classic. All right, so this patient, I think this is the 14-year-old. They didn't know anything about the TSH, presented to an emergency room with this is an adult patient, but a huge pituitary gland. What do you guys think? Same presentation, but he was having headaches, and somebody in the ER got an MRI because they're worried like he may have like a tumor, and he has like this huge pituitary gland. Now that his TSH is like 876, his prolactin's only 29, so it's just slightly elevated. What do you think? Huh? So I've seen this once. I don't remember if it's a board exam or a prep question. So this patient has severe untreated hypothyroidism. And if I would have gotten an MRI on some of these patients, you could see pituitary hyperplasia because of that TRH causing that. Yes, so you can have pituitary hyperplasia. So if you think this is a tumor and you go in there, no, the treatment is levothyroxine. So pretty cool. You can give levothyroxine to decrease the size of that tumor. So pituitary hyperplasia from severe untreated hypothyroidism. All right, let's see. Okay, this question I saw in when I was doing the MOCA peds, so obviously it's not my question. A 12-year-old girl is here for her well child check, and you notice that she has decline in linear growth velocity over the last 1 year. She has a history of leukemia with CNS involvement and required cranial irradiation. Family is also concerned that she has complained of increased constipation, hair loss, and fatigue. Which of the following tests will yield a diagnosis and can be measured in a random sample? How about the pig protein?
Our guess was TSH.
Yes, absolutely. Because the other ones, you really cannot be measuring in a random sample. So history of cranial irradiation puts this patient at risk for pituitary hormone disorders. And you are concerned about possible thyroid dysfunction, hypogonadotropic hypogonadism, adrenal insufficiency, growth hormone deficiency, and diabetes insipidus. An ACTH, you would usually get a fasting with a cortisol level, and a growth hormone level is really not very useful. It's pulsatile. You're really not going to diagnose or even screen for growth hormone deficiency with a growth hormone level. You would get an IGF-1 and IGF-PP3 level. So this patient actually would need a TSH. And the other thing, I don't agree with the question, is that they should have actually put a free T4, because cranial irradiation, you're thinking pituitary, and they may have central hypothyroidism, so they need a free T4 level. But the PEDS boards, they said TSH, so if there's free T4, you're going for both or free T4, okay? But they can also have primary hypothyroidism, so I think they were trying to make it simple. And then diabetes insipidus, you would obviously screen with a sodium level. You would get a serum osmolality and a urine osmolality. If it's not very helpful in the right context, they will need a water deprivation test. And with the diagnostic criteria where elevated serum osms greater than 300 with urine osms less than 300, as well as an elevated sodium. Oh, I've seen this before in a board exam. What do you guys think is the diagnosis? They just threw an X-ray in there. I had no idea. I totally missed it. Same, okay. All right, they love these questions though. I don't know why. It's Albright's hereditary osteodystrophy, right? So there's the inactivating GNAS1 gene mutation. It can have round face, short stature, brachydactyly, dental anomalies. The reason I saw it in board exam is because they have pseudo hypoparathyroidism, where they have resistance to PTH and other end organ resistance to other hormones too. Obviously low calcium, high phosphorus. We had a patient present like a year back, I don't remember, 10 or 9, presented with basal ganglia calcification a few months ago on MRI, and then came in with a hypocalcemic seizure. Calcium was like 5 or 6, PTH was 2200, which is very high. So she had pseudo hypoparathyroidism and possibly has Albright's hereditary osteodystrophy with genetic testing pending. But you'll frequently see they have like an X-ray or something that is characteristic of a genetic condition and ask for either diagnosis or what else would you find. So they could ask, what else could you find on serum, lab evaluation? They would think low calcium. All right, Dalton, I think you know this one. A 12-month-old African-American baby is seen in your office for failure to thrive. He's exclusively breastfed and does not receive any vitamin supplementation. On physical examination, he has a large anterior fontanelle for age and widening of the wrist. We did this question in endo. Yeah, 25 hydroxyvitamin D level. Classic, right? So we see this a lot of times in clinic, in the hospital. So this is nutritional rickets, where they can have a low or normal calcium, low or normal phosphorus, elevated alkaline phosphatase, increased PTH, and severely decreased 25 hydroxyvitamin D levels. They can present with frontal bossing, delayed closure of the fontanelles. You have the rachitic rosary with enlarged, it's the enlarged costochondral junctions. They can have widening of the wrist and bowing of the distal radius and ulna. They can, when they start walking, they can have bowing of the femur and tibia. So treatment is vitamin D supplementation, plus or minus calcium. I feel like all the patients that we see in the hospital probably needing calcium supplementation. Yeah. No. Yeah, I think, yeah, I think we just see the extremes in the hospital. Luckily, we actually don't see a lot of this even in the clinic. I think the pediatricians are treating this outpatient, but I think we just see the more extreme, the calciums of 6, 7.
Or do you think there's going to be something else that
No, you're gonna have, you're gonna have that classic history. African American, dark skin, breastfed, no supplementation. I would check. Yeah. Yeah, if this is the first, I'm hoping they're all on vitamin D supplementation, but if not, yes, you would definitely check, but you're gonna see some, hopefully some physical exam findings, and yeah, you would check. Okay. A 14-year-old obese African-American adolescent female presents with symptoms suggestive of diabetes. On 2 occasions, the fasting plasma glucose is 128 and 136 milligram per deciliter. What is the next diagnostic or therapeutic step? So you would actually begin treatment for diabetes. In real life, we would never do it, but she's got diabetes. She's got, if she fasting blood sugar over 126 and they repeated it because it was borderline, you don't need anything else. Okay, in real life, you would get an A1C and it would do maybe even a 2-hour post OGTT for A1Cs like 6.9. But the definition is classic symptoms plus random blood sugar more than 200, fasting blood sugar over 126, 2-hour postprandial blood, 2-hour post OGTT glucose greater than 200. Okay, and the treatment depends on what type of diabetes, but you know, this is an obese female. We're hoping we see signs of insulin resistance, and most likely we'll need treatment with metformin. Okay. All right, so I saw this patient last week. You're seeing a 9-year, 3-month-old Hispanic female for initial consultation of short stature, maybe precocious puberty. Patient recently started to have breast development and is Tanner 2 on exam in regards to breast development. Her bone age is consistent with 11 years of age, which is borderline advanced, which gives her a predicted height of 57, 58 inches. What is the most likely diagnosis given her final predicted height? And let's take a quick look at the growth chart, okay? This is a growth chart. And I have plotted the parent's heights, and the mid-parental height is about 57.4 inches. And this is where she's at right now. So a little bit like, tell me what I'm thinking kind of question. Yeah. Yeah, exactly. So familial short stature in this patient. So she's 9, right? So the 2 points. This is familial short stature, and she is not precocious because she is 9 and she's Tanner 2. So even if she started within the last 6 months, about 8, this is not considered precocious. So once they start making estradiol and that kind of bone age advancement, we see it frequently. So I'm not too worried about it, and it's borderline advanced. So even if she started within the last year, this is still normal. I should have told you guys her growth velocity is normal. Her, you know, if her mid-parental height was like at the 50th percentile, you know, not the greatest growth velocity, then you would think about other things like growth hormone deficiency or Turner syndrome. But I think I could have given you a little bit more information, but just for you guys to see, her mid-parental height is 57. So, you know, familial short stature is something that we can't do anything about if they're growing well, okay? The other things that I've frequently seen on board exams, familial short stature, constitutional delay, they love it. You know, what is wrong with this patient's growth velocity? What is wrong with this patient's growth chart? All of that, they love it. But remember, over 8 in girls and over 9 in boys. We only worry because of height prediction, all of that, but for board exam purposes, 8 for girls, 9 for boys. That I just, you know, this is not a perfect question. It was the real life, but I just wanted you guys to kind of see, okay, her mid-parental height is 57. She's gonna be 57. That's it. Like, we're not going to be, you know, worried that she's short. Like, I'm not going to be worried about Turner syndrome and all of that because she's got familial short and she's growing well. Okay. Yeah. All right. So this is Dr. Stallworth's question. Some of these are Dr. Stallworth who has shared some of his questions. So thank you, Dr. Stallworth. And this is one of his questions. So you're asked to consult on a 10-day-old patient who is severely dehydrated. On exam, patient has ambiguous genitalia. Of the following, the most likely laboratory finding you would expect in this patient would be? Oh, how about the NICU team?
Increased sodium.
No, try again. You're getting closer.
Increased potassium.
Exactly. What does this patient have?
Mineralocorticoid deficiency.
Yes, it has ambiguous genitalia, right? Okay, so this patient has what? CAH, exactly, right? So hopefully this patient's going to be diagnosed by newborn screen well before presenting an adrenal crisis, but it's we're going to think it's going to be a female patient who has ambiguous genitalia. We're not sure what the gender was assigned, but 10 days old is when they kind of start presenting crashing and in adrenal crisis. So they most common is 21 hydroxylase deficiency. So they have elevated 17 hydroxyprogesterone and all those precursors above there. So they are not making cortisol and aldosterone. So they are salt losers. They have no glucocorticoids and no mineralocorticoids. So they have hyponatremia and hyperkalemia and metabolic acidosis. The treatment is fluid resuscitation, glucocorticoids, fludrocortisone, or at home salt instead of fluids. I think for peds boards, I would focus more on 21 hydroxylase deficiency. They definitely will have some sort of question on either, I don't know much about, they would ask about treatment, but at least the diagnosis, recognizing usually it's a boy, if he's had a home birth, hasn't had a newborn screen, and at 2 weeks he's crashing, presenting to the hospital. And then, you have hyponatremia, hyperkalemia, and metabolic acidosis. So obviously, you're always thinking sepsis, but don't forget adrenal crisis as well. Okay, so these are just some of the things that I wish I had looked, or I know I've seen some of them, and I wish I had looked up some of these, and definitely look up some of these. Okay, they love this question, and I feel like we've also talked about this in the past. A patient has a 1.2 centimeter thyroid nodule. What is the next step? If you've done endocrinology, you're like, oh, well, we're going to send them to surgery, get labs, but what is the board answer? Sure. So say this is on ultrasound, 1.2 centimeters thyroid nodule. So you would get, so that you're going in the right direction, but you would want to get thyroid studies, because if it was in clinic, we'd be like, okay, this is a thyroid nodule. It meets criteria for a biopsy because it's over a centimeter in pediatric guidelines, and everything say biopsy, right? But clinically, in board answer is you'd get thyroid studies, just with a chance that this could be a hot nodule. So you've got to differentiate between a hot nodule and a cold nodule. The cold nodule could be cancerous. Hot nodule could be, just producing extra thyroid hormone, and it could be surgically removed and it goes back to normal. So if the TSH is suppressed, you think about an autonomously functioning hot nodule. Okay, so get TFTs. Don't send to surgery, not a biopsy. Huh? No, in the board. Yeah, you would get biopsy. You'd get everything at once. You'd get thyroid studies, but you would also send to biopsy. All right, they love these syndromes. Turner syndrome, Prader-Willi-Williams syndrome. You can have hypercalcemia with Williams syndrome. So they may ask, some classical findings, or, like physical features. And they may say, the patient also has hypercalcemia. We don't exactly know why these kids have hypercalcemia, but frequent finding on board exams. I do remember having a question about this, APS1 autoimmune polyglandular syndrome due to a AIR gene mutation. So they have hypoparathyroidism, anemia, Addison's pernicious anemia, and ovarian insufficiency and other autoimmune conditions. So we love this. And then I didn't go over MEN syndromes, but please look them all up. They board exams love, love, love MEN syndromes. You will definitely have a question. And then obviously learn about what other syndromes are pheochromocytoma associated with, like von Hippel-Lindau and Sturge-Weber syndrome. They may not ask you like the treatment or anything, but they'll ask you, you know, the patient has these findings and some other characteristics of like Sturge-Weber or something, and then say, you know, what's going on. So is Kelly here? No, Kelly's not on the, okay. All right, one other, always keep in mind peripheral precocious puberty. If you have suppressed gonadotropins, elevated like testosterone or estradiol, it's coming from a tumor or something going on with the ovary. And then if you have like say a 5-year-old boy who has no testicular enlargement, because testicular enlargement is the first sign of puberty in boys, but they have pubic hair, they have an advanced bone age and growth of the phallus, think about non-classical CAH. And they will give you, you know, testosterone's elevated to like, I don't know, 150, which is high for a prepubertal kid, and his gonadotropins are suppressed. So think non-classical CAH. And then I don't know if you would see anything on premature adrenarche, but also PCOS. If the testosterone is severely elevated, they've got elevated 17-hydroxyprogesterone level, definitely think about non-classical CAH or some other CAH. But, you know, also think about like a ovarian tumor or something with severely virilizing features and an elevated testosterone. All right, that's all I got. And that's all the syndromes that I can remember that from boards 6 years ago. So what do you guys think? All right, I got candy for you guys. I thought there would be more people. So what do you guys want? M&Ms, Kit Kat? Yeah. Okay. All right. All right. Share. Actually, are you guys going back upstairs? Oh, that's